So I think it's still morning. Good morning. Thank you for including me in this morning symposium. So I'm going to speak about smoking cessation, which is apropos given the topic today. And I titled this "Quitting is Hard, but You Can Do It" because I think it's important to encourage smokers, but to also be honest about the fact that quitting is hard. But the fact of the matter is there are more than 50 million former smokers in the U.S., more than there are actually current smokers. So smoking rates are going down. In New York City, the smoking rate is about 15%. But that doesn't mean that it's easy to quit. So this is my outline, quickly about tobacco use and cancer, some data on quitting at any age, medications, some treatment options, and I just want to touch on electronic cigarettes because they're certainly in the news these days. So I guess I'm going to start with a question for you. Which product is not approved for treating tobacco use? Nicotine patch, electronic cigarette, nicotine gum, or Chantix? So why don't you give it a shot? Okay, good for you. Most people got it right. So electronic cigarettes are really on the rise in terms of use, a dramatic increase. You can't go anywhere without seeing ads for this product. I shouldn't say this product because there are over 450 electronic cigarette products on the market. But it is not an FDA-approved, Federal Drug Administration-approved product. It does deliver nicotine, as does the nicotine patch and gum. But I just I'm going to sort of push this point home further. When my patients come to me for quitting and they ask me, Dr. Shelley, I just want to use the e-cigarette, my response to them really is, well, the data's not in on whether it works or not to help people quit. You see, if you go on Twitter and you go on some of these electronic cigarette blogs and websites, you hear a lot of conversations about people who are quitting using it, but there have been no adequate randomized controlled trials conducted in the U.S. There have been a couple of trials conducted outside the U.S., but they've been small and really difficult to interpret the findings. I think it's an interesting and encouraging events that's happened in terms of seeing how smokers are adopting this product. I think what it's telling us in the tobacco control world is that we don't have products that smokers want to use, actually, out there, because the use of the patch, the gum, the FDA-approved medications is actually rather low. A lot of people do quit on their own, but if you want to try and avoid the withdrawal symptoms, it is helpful to use medication. So I think moving forward, and I'll talk a little bit more about electronic cigarettes at the very end, what I think this product has shown us is that we need to do a better job of designing a product that replaces nicotine for smokers, but is also a product that they want to use, that they enjoy using. Because that's sort of the word we're getting from folks who are using this. It doesn't exactly mimic, nothing mimics smoking a cigarette. When you smoke a cigarette in 7 seconds, you get nicotine into your brain. And none of these products, including the e-cigarette, necessarily mimics that. One of the problems with the electronic cigarette is we don't really know how much nicotine people are getting. If I prescribed you the patch or the gum or the nicotine lozenge, I could actually go cigarette to medication and know the exact dose. So if you were smoking 15 or more cigarettes, I would give you 21 milligram patch. And that's another problem with the electronic cigarette. It's really not clear how much people should use it. So just what's so bad about smoking? I think everybody in this audience probably knows the answer. There's hundreds and hundreds of chemicals, many of them cancer-causing agents, that are released when the tobacco is burned. And that's because of a lot of the additives in there, but also just because of the tobacco burning releases all these thousands of chemicals. And this is just the first 65 that we know of. There are thousands. Actually, CDC just updated the number to 7,000. What about cancer treatment and smoking? And I think it's really important to note that patients who are being treated for cancer will often say to me, it's so stressful right now, I really don't want to quit. But in fact, it's really the best time to quit is before you even start getting your treatment. because smoking while being treated can actually reduce the effectiveness of the medication and increases your risk of a second primary, as well as increasing your risk of relapse and reoccurrence. And so it's, I see a lot of patients actually after they've finished treatment and they come to me for help quitting, and I really rather see them beforehand because actually there is growing data that in fact, basically the facts that I've put on here are true. The Surgeon General just released last year an updated report. It was the 50th anniversary report on tobacco and the harms and the consequences of tobacco use. And I say 50-year anniversary because if you remember, in 1964 was the first Surgeon General's report that reported the connection between smoking cigarettes and lung cancer. So 50 years later, that report is this thick and shows that smoking affects every single organ in the body and is related to multiple diseases that, not just cancer, but actually this new report shows that it increases the risk of developing diabetes, not just complicating diabetes when you have it, but actually increasing the risk of getting it. So one of the new chapters in that Surgeon General's report was specifically dedicated to cancer. And the data was really overwhelmingly sort of compelling, actually, in terms of what the dangers are of continuing to smoke while you're getting treated. So again, trying to emphasize this, the take-home point is you shouldn't wait till after, people shouldn't wait till after they've been treated to try and quit. I'm going to skip this because we just talked about CT scans and lung cancer screening. I think the other important thing is a lot of smokers will have smoked for years and wonder, what's the point in quitting? I've been already smoked for 50 years. I already had cancer. Perhaps I see patients who've had cancers are now cancer-free and sort of they're motivated. But during cancer treatment, again, a lot of folks aren't motivated. But here's some data from studies from Dahl, who's a British investigator, and it shows here, it's pretty dramatic, that if you quit between ages 35 and 45, your survival rate goes back to actually that of a person who never smoked. So the message here, and I'm going to show you a second slide that shows you quitting a little later, is that the sooner you quit, the better off you are. The sooner you'll get back to a risk factor that's equivalent to a never smoker. So I rarely see 35-year-olds in my office, unfortunately. When I do, I actually show them this slide and then show them the next slide, which shows you that the downside is that the later you quit, the less survival benefit you gain. But the upside of this slide that shows you is that you do gain benefit. And this is true at every single age. Because it's not just mortality benefit, there's morbidity benefit as well. So you're going to feel better within immediately. Your circulation improves, your breathing will get better, your clothes won't smell, you'll be saving money. There's immediate benefits to quitting regardless of thinking about the long-term benefits. But these two slides are supposed to, the take-home message are that really quitting at any age, there is a benefit in terms of survival. So why is it so hard to quit? Because smoking is not just a nicotine addiction, it's also a behavioral addiction. So if nicotine replacement therapy was dealing with, if it was just a nicotine addiction, nicotine replacement therapy would be 100% effective. But we know that at 1 year, most of the medications are only about 25% effective. About 25 to 30% of people will have quit at 1 year, who use the medications. And that's because it's obviously a very big behavioral component to smoking. People associate smoking with emotional stressors, depression, anger. They also associate them with activities, which can be just as powerful triggers. People come out of the subway, they smoke. They wake up in the morning, they drink their coffee, they smoke. After food, they smoke. So those are the kinds of things, we talk about them as triggers, that's important for a smoker to sort of disconnect, unlink between the triggers and their smoking habits. And that's the hard work, really, of quitting that has to be done. So that's what I work on when I work with patients. And so what's been shown in the guidelines, the review, there was an update of the tobacco use treatment guidelines in 2008, meta-analysis of over 8,000 studies. It showed that combining medication and counseling is probably the most effective way to help people quit. They each have their own effectiveness alone if people don't want to use medication, but together they're more powerful for people because you have to work on both of these issues. So these are just a list of the FDA-approved medications for smoking cessation. There's the gum, lozenge, the patch. Those are the over-the-counter medications, and the prescription medications. There's also nicotine nasal spray, nicotine inhaler called Nicotrol. There's Zyban, which is the only antidepressant that's approved for treating smoking cessation. It's also called Wellbutrin. And then there's Chantix or varenicline. And I don't have a lot of time to go into all of these, but the last updated review demonstrated, and again, the data wasn't head-to-head. There's very few studies that actually take these medications and put them head-to-head, comparing them to each other. Overall, they double or triple quit rates. So if your quit rate was 10% without medication, you use one of these medications for 3 to 6 months, your quit rate's going to be something like 20%, 25%. When Pfizer came out with Chantix, they did do a head-to-head with Zyban and actually showed Chantix was more effective. And so the latest updated guidelines, as I was talking about before, in 2008, suggest that actually the most effective medication choices are either Chantix alone, which tripled quit rates consistently, or combining a long-acting nicotine replacement therapy and a short-acting. That would be the patch, plus either the lozenge, the gum, the inhaler, or the spray. And honestly, we used to have all these cutoffs about how many cigarettes you smoke, but the truth is that 75% of smokers are underdosed in terms of nicotine replacement therapy. So every one of my patients who wants to use nicotine replacement therapy, I combine it with a patch and one of these short-acting medications, unless they're smoking, probably less than 5 a day. Most of these drugs were approved for people who smoke 10 or more cigarettes a day. We're finding, though, increasingly, because of the price of cigarettes, that we are seeing increasingly people smoking less than 10 a day. That doesn't mean that they're not still addicted to nicotine, and they still may need medication. We call them light smokers, and in fact, over 60% of smokers in New York City now are light smokers. That's because if you've bought a pack of cigarettes lately in New York, you'll know that it's almost $15 a pack, which is pretty astonishing. So these are the different medications. There are obviously some side effects associated with some and some contraindications, but the over-the-counter ones, obviously, you can just pick up from the store. These are generally covered. The Affordable Care Act, Obamacare, actually includes in it coverage for smoking cessation. We in the tobacco control community don't really know quite how that's playing out, but technically, your insurance company should pay for treatment for smoking cessation. So if you're not able to buy the medication, you should be calling your insurance company and finding out why, because these should be covered now. Why use medication? Because withdrawal symptoms are terrible. They stink. It's why most people within 24 hours of quitting, relapse rate is highest within the first 24 hours of trying to quit. Why? Because you wake up in the morning, you haven't smoked for 8 hours, you say, I'm going to quit, and by 10 o'clock or 11 o'clock, you're starting to really feel anxious and irritable, have difficulty concentrating, and all these other side effects. Most symptoms do go away within 2 to 4 weeks, but it can take a while. And so this is one of the reasons, if withdrawal symptoms are really a problem and have caused relapse for a smoker and have really been one of the things that's been the most difficult, those are the kind of patients that I really encourage to try and use these medications to help avoid the withdrawal symptoms. Why put yourself through that when it's hard enough trying to deal with some of the behavioral issues? So where can you get help? We actually, every state in the country has a quit line. We have one too, 1-866 New York Quits. Counselors trained to talk to you. You can call 311 in New York City and they'll hook you up. It's convenient. They'll also send you 2 weeks worth of free medication, patch or gum. There are web-based programs that some people find fun. If you like to be on the web and you like to be part of a web community, nyc.gov has an NYC Quits website, and becomeanx.org is one that's actually been tested and shown to be evidence-based. And there's also a text messaging program that I really like. So you put your quit date in there. You go to this website, smokefree.gov/smokefree text, or if you just look up smokefree.gov TXT, what they do is they send you 2 to 3 times a day. They'll send you a very supportive text messaging. I signed up for it, did it for a couple of weeks. And I actually enjoyed it. Of course, I wasn't trying to quit, so maybe I wasn't the best test case. But I actually do, if people want to be kind of during the day supported and reminded that they're quitting, it actually is a useful tool. And increasingly, studies are showing that text message support increases the rates of quitting. And finally, we have some programs here. We have actually the integrated, I think it's what it's called, the Integrated Health Wellness Program, has hypnosis, there's acupuncture, but if you want sort of the bread and butter, smoking cessation and medication management, I work with patients, I see patients at the Cancer Center. What's nice is we actually set up an NYU central number for smoking cessation called, and that's the number 855-NYU-QUIT. And they will give you the number for the quit line, or they'll give you my number, or there's the rehab center has a program. So you can just call, if you can't remember the 731 number, you can call 855-NYU-QUIT and just listen to an operator tell you what some of the other options are. So I'll skip that and just get to this, and just to say the electronic cigarettes are battery-powered devices, and when you inhale, it heats up the battery. The battery heats up the fluid, I should say, which vaporizes the nicotine, and you inhale it. More and more, you probably see people using these. They're on the streets. There have been almost no studies. The FDA now has put out over $300 million worth of grants now. They started these big centers. They funded about 10 center grants to study alternative tobacco products, and including electronic cigarettes. So we're hoping in the next year or so to start to get some data on the safety. They are clearly safer than cigarettes, but there is, when you inhale them, you're inhaling propylene glycol. That seems to be the main chemical constituents of what's in the vapor. So it's not really clear what the safety profile is. I wish I had more answers for you, but we just don't. They have been banned in use indoors in New York City. Actually, e-cigarettes were added to the smoke-free air law. So you're not supposed to, that's why you stop seeing people smoking them indoors, actually. But that wasn't because of the evidence that the secondhand vapor was dangerous. It was really more to avoid losing ground on the social norm change we had in New York City, right? So if you saw someone using one of these things that looks like a cigarette in a restaurant, you start to think, wait, what happened? I thought that was illegal. And, oh, we can smoke? Great, you know? So we really didn't want that to happen. We've made so much headway in changing the social norms here. So you can't smoke indoors, e-cigarettes, and we actually included it in the new 21 law where you're not allowed to buy cigarettes unless you're 21 or over now in New York City. Generally, it's 18 and over around the country, and that includes e-cigarettes. There is no scientific proof it helps smokers quit. I'm actually doing a study right now funded through our NYU Center for Translational Science, looking at it as a harm reduction method, seeing whether people can actually reduce, and we're seeing that using this regularly with some support through text messaging actually does help smokers reduce the number of cigarettes they smoke per day. We're hoping to actually do a randomized control trial to see whether e-cigarettes can actually help people quit, because there is a lot of demand for a product like this, actually, from smokers. But again, we just don't know the answer yet. So my advice is to use what we know works, the FDA-approved medications, until we find out more about e-cigarettes. That's it. I also